Hi there. I just need you to let me share screen. There we go. Can you see the slides, guys? Can you see the slides?
Yeah. Yes. Yes. Okay.
Great. Thank you very much. So again, I'd like to start by just thanking the panel for inviting me to speak. It's a very kind offer. And I'm going to be talking about ballooning uncrossable lesions. And obviously, you'll see a couple of cases of where I use the alveo balloon actually to help facilitate these challenging group of PCI cases. So just to go over some of the basics again, I know we've already had that fantastic talk by Jenny Huang, which I thought was really informative actually at understanding the true benefits of the alveo balloon in particular. But so sort of starting at the beginning, a balloon uncrossable lesion really is defined as a lesion that cannot be crossed after successful guide wire crossing and confirmation of guide wire placement in the distal true lumen. As you can imagine, often, particularly with CTO, crossing the lesion with the wire is the most challenging part. And once you've done that, being unable to deliver equipment to complete the procedure can be very difficult for you to deal with mentally. So it's important to have a strategy in place to try and deal with that sort of consequence. And this sort of lesion of balloon uncrossable lesions occurs in up to 10% of CTOs. But as you'll see with some of my cases, is also found in non-occlusive lesions as well. So it's an important skill set and important to have the understanding of equipment that you can use to facilitate you in this situation. But when you're faced with balloon uncrossable lesions, usually it's due to severe calcification and or tortuosity of the vessel at the site of the lesion. And I'll show you a couple of cases that kind of highlight these things. Now, before we start, I'm going to just show this algorithm that is published by El Reyes and colleagues from a couple of years ago, which kind of highlights an algorithmic approach to balloon uncrossable lesions. And you'll see there's several steps, 9 steps in total, but the aim of each of these steps is to firstly modify the lesion and secondly increase support for delivery of equipment. And you'll see that there are several steps, but I would say that actually number 9 is probably the most important, which involves using simultaneous application of lesion modification and increasing support to increase your chances of crossing these difficult cases. And you'll see from the cases that I show, and I'm sure from the other colleagues on the panel, of why using combinations up front is often required. Okay, so going straight into the cases. The first case is a 68-year-old gentleman, had an acute presentation with anterior ST elevation. Troponin was 720, no other modifiable risk factors, and the ECG is shown there with anterior ST elevation and T-wave inversions. The first angiogram here shows this critical lesion in the mid-LAD. You also see from the second video there that there's a chronic occlusion of the circumflex, which is actually quite a large vessel, which is trifurcating beyond the point of occlusion. And you see some retrograde filling of that via the apex. Just for your information, the right coronary artery was a large dominant vessel, relatively free of disease. So in the initial acute presentation, we proceeded to treat the LAD as the culprit lesion, use the equipment as described, an EBU guide cath, BMU wire, some ballooning, and then a couple of stents implanted in the LAD with an excellent angiographic result, as you can see there. So at this stage, we decided to try and move on to, once the patient was stabilized, had an echocardiogram done showing preserved left ventricular systolic function, optimized on some medical therapy, but had ongoing symptoms when followed up. So we decided to proceed to PCI to the left circumflex CTO. So you can see our setup shots here already. You see that circumflex lesion as described, and you'll notice particularly from the second video panel there that there is quite a lot of tortuosity and angulation in the proximal circumflex before getting into the distal vessel, which is where the particular challenge lies. So we set up from the outset to have increased support. We use a 7 French EBU4 guide catheter. We had a plan for antegrade wire escalation. There wasn't really a retrograde option here, as the retrograde filling of the circumflex system was only via the apex from the LAD and diagonal system. We up front used a microcatheter, which was a Corsair in this case. And you can see from the image just shown that there was a challenge here of the tortuosity developing once you're in the lesion with your wires. We've crossed the kind of proximal cap, but now you can see that we're having real struggle to push microcatheter beyond the lesion and to get the rest of the wire, the rest of the vessel wired successfully. Ultimately, though, we did manage. You can see that the wire is in. I think we used a Fielder XT essentially to get across. Still, you see a lot of buckling of that Corsair microcatheter to try and get beyond. But ultimately, after a lot of manipulation and torque, we managed to get into the distal vessel, and you can see that wire position was confirmed with the distal tip injection, which we used in this case just because there was no real retrograde option to visualize properly, and we were able to pick off side branches. So relatively confident in doing that technique. So ultimately, the lesion was crossed with the Pilot 200. We advanced the Corsair. The true lumen position was confirmed. And now we switched to a stiffer, more supportive wire, which was a Grand Slam. And we tried crossing with a 1/0 balloon, were unsuccessful. So we upped our support even further by using a 6 French guidezilla, and then we tried with the Alveo 0.75 by 15 balloon, which you can see here in the video, has crossed the lesion and allowed us to inflate and predilate. Once you predilate the lesion, actually, even with this small balloon, you start to see what is the true vessel really looks like. You see is this trifurcating system with quite a large caliber OM2 and a reasonable caliber OM1 as well. So we ended up performing a bifurcation PCI with the TAP technique and a couple of stents implanted into that circumflex OM1, OM2 system with a good angiographic result. So in summary, this was a CTO of the left circumflex in a patient with ongoing symptoms after their index presentation of a STEMI and PCI to the LAD. So we performed successful PCI using techniques to facilitate crossing this balloon uncrossable lesion. We upfront used guide support with the 7 French guide system and a guide support with guidezilla. We upfront used a microcatheter. We then, once crossing the lesion, used a stiffer wire, and that allowed us to facilitate delivery of our Alveo balloon and then give us the sort of starting point to be able to complete the procedure with a good angiographic result. Okay, so I'll move on to another case now, a slightly different flavor here. This is a 63-year-old gentleman who presented acutely with an N-STEMI, troponin elevated at 120, ECG shown there, shows sort of no real acute changes. This patient did have risk factors including hypertension, hypercholesterolemia, and an ongoing smoking history. And an echocardiogram prior to the procedure showed preserved left ventricular systolic function without any significant valve disease and no resting regional wall motion abnormalities. This is a diagnostic angiogram. So you'll see here that the LAD, from the second video in particular, you'll see that there is quite an angulated calcific and tortuous lesion in the mid-LAD, but actually a very good caliber vessel beyond. The right coronary artery you see here is mildly diseased throughout, but without any significant lesions. So we proceeded to perform PCI to the LAD. And again, you know, we were under the impression that with the calcification and tortuosity, this may be a challenging lesion to not so much to wire, but more to cross with equipment, in particular balloons, and then obviously delivering equipment beyond that. So we went up front using a 6 French Prelude Ideal hydrophilic sheath, which allows a 7 French guide catheter in because it's obviously a thinner braided sheath. We use a 7 French EBU guide catheter. And we used already up front a 7 French guide liner to give us a bit more support. We up front used a fine cross microcatheter, and we used a cyan blue wire to cross the lesion, which helped at least get to that point. But from here onwards, we were unable to advance the microcatheter beyond the lesion, despite our support we already have in place with a 7 French guide catheter and a guide extension, guide support system with a guide liner. So that was obviously where we now had to start thinking of our strategy to use to the algorithm for balloon and crossable lesions here. So ultimately, you know, we did manage to predilate with an Alveo 0.75 millimeter balloon, which you can see from the video there. This was actually, I must say, quite easy to deliver, but you can see from the video a little bit of bowing in the proximal LAD from that initial kind of push and wedging the balloon into place prior to our first predilatation with that balloon. Once the first predilatation balloon occurred, actually, it kind of allowed a little bit of give, and the balloon could then be delivered further into the distal segment of this mid-vessel lesion. After that, we were able to then further predilate sequentially with a 1 millimeter, then a 2 millimeter balloon. And now we were able to deliver our fine cross microcatheter into the distal vessel and switch out to a supportive wire. And we switched out to a Grand Slam in this case. So I'm a very big believer in intracoronary imaging, particularly in cases like this where you're having challenges and you want to understand what your problems might be. So we performed a pre-PCI OCT. As you can see here, using the MLD approach for looking at the morphology, there's a lot of fibrotic tissue, a lot of calcium, an arc of around 270 degrees at the mid-vessel. And obviously, we're able to determine the reference vessel diameter, both distal and proximal to the lesion, and measure the length appropriately from there to help us plan our strategy. So now that we've obviously used our initial small balloons to help us deliver equipment, we then decided to up things, and we performed intravascular lithotripsy with shockwave using a 3 millimeter balloon in the mid vessel. Used 40 pulses. You can see from the still there that the balloon's well expanded, and we did a final pre-dilatation with an angiosculpt balloon as well to kind of make a bit more space within the cracks and crevices of the calcium and fibrotic tissue. And we implanted 2 stents, firstly a 2.75 by 23 in the mid vessel and a 3.0 by 23 more proximally. We did a post-PCI OCT as you would routinely do in this case. You'll see from this run, there's a couple of areas where there's malapposition and underexpansion, but we obviously used that to then do some further post-dilatation with 3.25 and 3.5 non-compliant balloons. And you'll see here a final angiographic result. Shows that the lesion is very well treated with good expansion, good apposition of the stent from the OCT, and a very good angiographic result in what is a very big and important vessel for this gentleman. So to summarize this case, this was a successful PCI of a fibrocalcific lesion, which was a balloon uncrossable lesion in the mid-LAD. We did successful PCI using the techniques to facilitate crossing with, again, upfront use of a guide support system, 7 French guide and a guide liner system here. We upfront used a microcatheter. We then switched out to a stiffer wire once we've crossed and been able to deliver our equipment after having ballooned with a micro balloon. And then we used atherectomy type techniques with the shockwave and the OCT optimization to achieve an excellent angiographic result. So again, obviously, I know Jenny spoke in detail about some of the real benefits of the alveolar balloon, and I think I will only echo those sentiments by saying this is a very ultra low profile balloon with a low profile tip to kind of allow for crossing into the lesion to start your pre-dilatation. It also is obviously small in itself at 0.75, being the smallest balloon available, and it does allow high pressure inflations. Can go up to 20 atmospheres quite easy. I mean, I'll be honest with you, I've certainly taken it up to higher than that, 24s and 28, so it can tolerate that in most cases quite well. So yeah, a good balloon to have in your arsenal when facing CTOs or complex lesions or heavily calcified lesions, as demonstrated here. So I guess my final thoughts are really to say that, again, referring back to that algorithm that was published by El Reyes and colleagues, that there are options available to you. I think it's important to strategize up front of your procedure by combining a lot of these techniques, perhaps up front with things like, extra support from the outset, increasing your support during the case, and using techniques to allow balloon crossing. And then once that has happened, you may then need to upscale to things like atherectomy techniques as well, like rotablation or laser, or using things like shockwave if it's deliverable, prior to then getting into your final result. So I hope those cases were interesting for you as the audience. I open the discussion to any panel members or audience members if you wish. Thank you very much for your time.